Good evening, and welcome to the REMI Institute. Today's webinar is Clinical Applications of Extended Duration EEG Monitoring, Lessons from Real-World Cases, presented by Dr. Timothy Ryan. We'd like to remind our reviewers that these presenters are paid consultants of Epitel. The cases, techniques, and views shared in this webinar are those of the presenting physicians based on their independent medical practice and do not necessarily reflect the official policies or specific product claims of Epitel. Results from these case studies may not be predictive of results in other cases. Today's webinar is brought to you by the REMI Institute. The REMI Institute is Epitel's education initiative focusing on advancing EEG care through clinical education, real-world experience, and meaningful collaboration within the neurology community. Through webinars like today's, clinical case discussions, practical training resources, and ongoing education content, our goal is to help expand access to EEG monitoring while supporting clinicians in their day-to-day practice. This webinar marks the launch of the REMI Institute, and we're excited to have you with us for our inaugural program. If you enjoyed today's session, we invite you to subscribe to receive updates on future webinars, educational resources, and new REMI Institute content. With that, it's my pleasure to introduce today's presenter, Dr. Timothy Ryan, and this REMI Institute webinar.
Good evening. Thanks for having me. I'm Dr. Timothy Ryan, Medical Director of the WakeMed Hospital's Epilepsy Monitoring Unit and a partner at Raleigh Neurology Associates. Tonight, we're going to be talking about clinical applications and extended duration EEG monitoring, lessons from real-world cases. So the star of today's show is the REMI remote EEG monitoring device. In the center of the screen, you can see an example of the phone that acts as a repository for the data and a device to upload the data that is collected from the REMI electrodes. When the REMI is fully set up, there are 4 sensors, 2 on the forehead and 2 behind the ear to build the 10-channel montage. What's nice about the REMI device is its practicality. So there's a simple patient setup. These are wearable sensors that are designed for rapid application. We all know that there's a shortage of EEG techs, only 14 EEG tech schools nationally. So having a device that's easy to put on by a technician or a medical assistant or a nurse, and easy for a patient to readjust or remove if they need to shower, or for a parent to put back on if a patient is agitated and rips it off is really important. Dramatically different than a traditional wired EEG device. Additionally, these leads are wireless. And so this device is really the first that allows for unencumbered real-world evidence information, based off patients' day-to-day activities. Patients can wear this wireless device and exercise, they can go to work, they can get stressed, they can do the things that produce the events or seizures that we want to capture. Most patients are not living in a hospital bed for weeks on end, and so the epilepsy monitoring unit isn't always the real world. Nicely as well, if the phone aspect of the device is uploaded to Wi-Fi, the EEG recording is securely transmitted up to the cloud. And so you don't need to wait until the end of the transmission to get your 72 hours of wired EEG data and have to sit down over your lunch and crunch through all those hours. Instead, live while the device is running, you can jump in and out, read a little bit of EEG there and here and there, or touch base and take a look at the EEG when a patient actually has an event. Nicely, even though this device is novel and has a lot of advantages, it smoothly works with established EEG workflows. The data is transmitted through Persist Mobile, and it's easily accessible through a website. The device is approved by the FDA for 1 year of age and up for up to 30 days of monitoring when clinically appropriate. So this extends EEG monitoring and the collection of data to new horizons. And finally, the device is, very focused on ambulatory care and use outside traditional inpatient monitoring environments. So here's an example of a patient wearing the device, a younger patient like we talked about. This is something that can be used in children and adults. He looks nice and happy having a wireless device that's minimally invasive instead of having a big wrap with wires that need to be braided down into a backpack. And he's able to do his daily life and hopefully provoke the event of interest. Looking at the montage in the center of the screen, we have an idea where our electrodes lie and where they reference on a traditional 1020 montage. So we have two frontal electrodes and two, temporal electrodes, which build this 10-channel montage, which is shown at the bottom of the screen as you would see it live through Persist Mobile. Another focus here is the AI for event detection REMI Vigilance program. This is an AI annotation device that runs after the data has been collected to help annotate events and mark them as a low, moderate, or high confidence event so that after I've reviewed the EEG, I can focus in on the things that are particularly concerning to REMI vigilance. Additionally, the patient can use the phone device to annotate the EEG themselves, talk about meals, talk about events, and describe what they're feeling instead of having to have a paper diary like we often have for wired ambulatory EEG. So for those of us who are in, neurology clinics or epilepsy clinics especially, there's three big scenarios that come up on a really weekly basis where we think about extended duration monitoring. The first scenario is the patient that has events that are not occurring commonly. We know patients with epilepsy sometimes have events only once a year or once every few years. We know from responsive nerve stimulator data that some patients have very late circadian rhythm events, at monthly or biweekly or even further out time points. And so what do you do for these patients? Historically, you crossed your fingers and hoped for the best. You hoped that your 72-hour wired ambulatory caught the event and you said, hey, if it didn't, maybe we get some, interictal discharges and we have some suspicion. Or you ask them to set their life on the side and go live in the epilepsy monitoring unit for weeks. Nicely, the REMI device allows for a new solution. It allows for us to have hope when patients say, oh yeah, I only had this event every couple weeks or every week. It also allows us to have a device that we can send patients home with and they don't need to take big steps away from life or work. A second common clinical scenario when it comes to using the REMI device and just in a neurology clinic in general is are these symptoms truly seizures? We know that the epilepsy monitoring unit is often used for event characterization and seizure differentiation. Seizures can be weird. They're not always the perfect pattern or semiology. Sometimes they can be just flushing. Sometimes they can be headaches. Sometimes they can be visual obscurations. This allows us to put something on a patient and not force them to come into the unit necessarily, where we prefer to have surgical cases to, kind of answer the binary yes or no about whether this is likely a seizure or whether we need to think about medications. Finally, the REMI device helps us characterize recurring symptoms, especially in patients with epilepsy, but also patients who don't, to support long-term epilepsy management. For so long, we have driven medication titration and medication initiation through guesswork, through a gray zone that has not been data-driven. But now we can have a device that lives on a patient for days, if not weeks, to drive those decisions in a data aspect. So we already focused on a few of these clinical use cases on the right, but the REMI device allows for a lot of creativity given these new horizons and these new time windows. One, thing that we haven't jumped into yet, but is really important is expanding access to EEG. Like I said before, there's only 14 EEG tech schools nationally, and we know that the average Medicare patient drives 50 miles to see a neurologist. There are many areas of the country, if not the world, that are EEG deserts, and patients are not able to get to a wired EEG easily. It can take hours, or they need to wait months to get a traditional EEG. And so this can allow patients to get something earlier and get some data to drive care. Additionally, there's long wait times for epilepsy monitoring units nationally. There's not enough units, and a lot of units, at least in my area, take 6 to 12 months to get into. Once again, this can be an initial stab at trying to characterize an event, characterize a seizure, and decide who needs to go to the EMU and who doesn't. And then finally, there's a lot of exciting potential uses for a REMI device and extended duration EEG to guide real world monitoring, to make parents who have patients sleeping with epilepsy more confident that sleep is safe. For patients who go out into the real world, maybe having a world where there's a seizure detection aspect of the EEG data collection. These aren't things that are approved with the device at this point, but there's a lot of creative ways that I hope the device will expand in the future. So first, let's jump into a real world case from my clinic from example one. So there's individuals whose symptoms occur infrequently, like we talked about, who aren't going to be captured on that short duration EEG monitor. We know that a routine EEG has about 30% sensitivity for capturing an event, and even a 72-hour EEG caps out around 80 or 90%. Those last percentage points are meaningful to real patients. So this was a patient that I saw in my clinic. She was a 39-year-old woman who had a history of a pediatric onset epilepsy, which she believed had been resolved. She'd been told as a teenager she grew out of it. Her, seizures had gone away. She was successfully weaned from medications. But she was concerned. She had been off seizure medications for greater than 10 years, but she was starting to have intermittent brief lapse of consciousness and shaking every few weeks. She still wasn't sure what was going on, but she was suspicious that this might be epilepsy coming back. So we were able to get her the REMI device. And one reason I really thought about the REMI device, and something I wrote in my note when I sent for billing, was her events were rarer than 72 hours. I didn't want to hope and cross my fingers that we capture the event. I really wanted to capture them. And nicely here, we were able to capture 3 focal seizures, which had a frontal predominance. And all of her events occurred after the traditional 72-hour monitoring window. So if I'd gotten a traditional wired EEG, I might have just told her, yeah, they're not seizures and you're still seizure free. But nicely, we were able to capture a nice seizure, which had a nice onset here with these lateralized periodic epileptiform discharges in evolution and amplitude and frequency. And then finally, a devolution and subsequent slowing in that area. So we were able to confirm focal epilepsy in a data-driven way, which would have been missed with a traditional wired unit, at least in my clinic. We were able to start anti-seizure therapy, specifically levetiracetam, with this patient, and it was able to reduce seizure frequency and intensity. And so extended duration monitoring provided diagnostic clarity where standard duration ambulatory EEG would have failed to capture management changing seizures. So I'm very thankful that I took this approach in this patient. And then we'll jump into case 2. So some patients have atypical symptoms or strange symptoms that require additional monitoring to help differentiate epileptic seizures from non-epileptic events or other neurologic diseases. So this was a 57-year-old man. He actually had a long-standing history of generalized epilepsy, but he thought he had been seizure-free for 30 years. He had a very laborious job that, required him to do a lot of heavy lifting, and he would sweat every day. So we were very, concerned that a wired EEG would not stay on for longer than a few hours in a work setting. But he was having a new event at work, which were these episodes of patterned heavy breathing during physical demanding work. So we had to work outside the box, and the REMI device was a great fit to capture this real world event. So we were able to capture multiple patient reported events. He was able to annotate them nicely on the phone. And nicely here, we didn't see any electrographic seizure activity during the event or any epileptiform correlate. And we saw instead was what we typically see on a REMI for a background, of a normal EEG, a low amplitude mixed frequency background during the symptoms. So I felt very confident that this was not a new type of seizure that we needed to treat aggressively. So we were able to kind of answer that binary yes or no seizure question confidently. We didn't need to make medication changes or start a new medication, which could potentially cause harm. And the patient was really reassured. I was able to show him the device or the data from the device, and he was able to continue his daily activities without disruption. So the REMI ambulatory EEG here enabled efficient and convenient event characterization and data-driven care decisions without needing to take time off his life or off from work to get information. And then case three. So, patients with epilepsy and patients with neurologic disease evolve over time. As the brain gets older, symptoms change, new seizure types develop. And so it's important to be able to pull longitudinal data to help evaluate for potential epileptiform activity and support treatment decisions. So this was a 52-year-old man who came to me. He had a history of childhood meningitis, which for epileptologists is always a little bit of a red flag and increased risk of developing epilepsy later in life. But he'd had long-standing episodic deja vu for years. He was a very successful patient. He'd had a successful career. He just thought that having deja vu a few times a year was normal and wasn't something that other patients didn't experience. But in the last year, it started to increase in frequency. And so that became concerning to him. Still wasn't interfering a ton with life, but he recognized that something might be changing as his brain was aging. So we were nicely able to use the REMI device, which had some big pros with him. He was still actively working, so he didn't want to take time off work. Luckily, telework allowed him to wear the device and hide it a little bit. We were able to capture these events, which he was able to annotate. And there was this associated interictal frontal rhythmic activity about 4 hertz, more characterized as like a bird, a brief rhythmic interictal discharge than a classic seizure, but it had a nice abrupt onset and offset. And it had a great clinical correlate. And so him and I were able to make a shared decision based off this data. So we were able to make a shared decision based off data instead of just living in the gray zone to start lacosamide. And he's currently episode free. And so, I hope that as we use this device more and more, as I use it more and more in my practice, I'm able to move away from the guesswork of initiating or titrating medications in patients and actually use data that's actionable to enable a shared confident treatment plan. So these are three common clinical scenarios that I run into in clinic, but there's certainly more uses for the device. I mean, some other cases that I can think of off the top of my head, I've had patients who've gone into the epilepsy monitoring unit and only been able to stay a week and have been disappointed that we didn't capture their event. So it's been a nice adjuvant to build upon that population to extend them to even longer time zones. We have a lot of pediatric patients in our practice who are not necessarily able to wear a wired device because of safety or because they'll rip the device off. And nicely, this device can be re-adhered by a patient or a family member. So we've had patients who've had severe developmental delay who has not had seizures longer than 30 minutes for decades start to get more information to help build their care plan again. So these are some clinical use cases around this, circle over here with the star of the show, the REMI, but certainly we don't need to limit ourselves to those cases. Just like ordering any other test or lab, clinical questions should guide the choice of EEG monitoring. And so certainly having the clinical question and answering it with the right data is important. It's important for the clinical decision making, but also for documentation. When you move this device to successful billing and documenting for the EHR, you've got to explain why you need an extended duration EEG as well. Extended duration EEG may provide additional insight beyond traditional monitoring windows. We know that at the 72-hour mark, we're not putting that sensitivity all the way up to 99%, especially in an ambulatory setting. And real world monitoring is ideal. Patients talk to us about the real world. They don't live in the hospital. They don't live in a hospital bed. They're talking to us about the event that's triggered by a fight with their spouse or the event that's triggered by jumping on the treadmill. And so we need a device that's able to be worn in the real world and to upload continuously to the cloud in the real world so we can check in on those patients and give them feedback when we capture their events. EEG data and EEG data that is more comprehensive and longitudinal can support confident clinical decision making, not only for physicians and providers, but shared clinical decision making with patients who suffer from epilepsy, which is unfortunately typically a lifelong disease. So I invite you to continue the conversation and stay connected with the REMI Institute. Like our team had highlighted before, there's a QR code here to subscribe for future webinars, clinical case reviews, and educational resources. If you have any questions that you don't want to bring up tonight, feel free to email the REMI Institute at epitel.com email. And if you're interested in the REMI, we have members of the Epitel team with us today to help answer questions along with me. And certainly, representatives from Epitel from their sales team can come to your practice and show you the device. Well, thanks for having me. I really appreciate the attention late in the evening tonight. We're going to open up the floor for, any questions and answers. I do have the Chief Medical Officer, Dr. Ferran, on the line with us for any very complicated questions, but we're excited to build upon this conversation and learning about, the REMI device.
Thank you, Dr. Ryan. We do have one question that's come in.
Yeah, so I think that's a question focused on PNES or psychogenic seizures or functional neurologic disorders. So, yeah, that's certainly a use that's pretty common in my practice. Like I talked about before, the epilepsy monitoring unit in a perfect world is primarily reserved for patients that are going to get a surgical evaluation. We want to get patients to surgery who need surgery. A lot of patients, we have a pretty high suspicion for psychogenic or PNES events based off clinical characteristics, but we want additional confidence and some data to share with them in a clinical setting. And so certainly have put it on patients who, are talking about these events that are, highly emotional or highly suggestive of PNES as a first step to have some shared decision making about, hey, should we start a med or should we go to cognitive behavioral therapy? I realize that sometimes video is very important for these patients. So if the REMI doesn't answer me and the patient's questions, sometimes we move on to the epilepsy monitoring unit, but it helps reserve that unit for the patients that truly need it and keeps it from being overwhelmed just by psychogenic seizures.
Another question we have often, Dr. Ryan, is the operational and logistical side. I don't know if you could speak to just your experience in your practice on those fronts.
Yeah, sure. So this nicely fit into an existing workflow. And I know that was a big concern of mine as, the director of our EEG lab at our private practice, as well as the medical director of the hospital neurodiagnostic lab. I not only was concerned about fitting into the workflow, I was also concerned about really cutting out our bottom line when it came to traditional EEG, which was very, robust already. Nicely, it's been an adjuvant and has really fit in a lot of different ways and in easy ways. First of all, any technician who can place a wired unit at this point can easily place these leads. I mean, placing these leads and setting up the devices is much easier than a traditional wired device. And so, there was not a ton of education that was needed for our internal staff. We did build a new order specifically to trigger this extended duration EEG subtype, which was easy to do in our EHR. And I've spoken to other practices that have done it, in Epic as well. I've done it in Athena Health personally, and that flowed nicely for the order. The patient experience has been very positive. They liked the idea of having the wireless device, being able to take it on and off for showering. Epitel does have a hotline for patients to call if there's questions or any type of troubleshooting that needs to occur while the device is being worn. Because it's easy to place, it's also helped us shorten scheduling windows. Placing a traditional ambulatory device took half an hour to an hour for our techs. And so we're able to usually place this device in 15 to 20 minutes. And so it's allowed us to fit in more extended duration EEGs. We've used it in a pinch too, where we've run out of units with our ambulatory wireless units, and we've been able to easily transition over here. And then on the back end, it's very easy for patients to bring back in the unit and the leads to just deposit. Once the data is brought back, the REMI Vigilance AI runs that algorithm, and then Epitel nicely notifies our lead tech or the physician that the data is ready. It feeds nicely into like a templated initial note, and then we review all the data and kind of write our own style note, on top of that template, upload it to the EHR, and then share it with the patient. It's been pretty seamless fitting it into our workflow.
Around sports concussions, what do you see as the REMI role with concern or return to play, for example?
I think concussions certainly looked at the use more and more of quantitative EEG to help guide return to play. Also, when you worry about, concussion subsequent to a seizure and a fall, or concussion going more on the spectrum of a traumatic brain injury, we know patients have a risk of developing, seizures and epilepsy. And so when I've had patients with a later stage concussion-like symptoms, I think that's somewhere where you might consider getting an EEG. A lot of the patients that are coming in for concussions are more active and often athletic. A lot of them don't love the idea of getting a traditional wired EEG and not being able to go with some weights or jump on the treadmill. So I could certainly see a fit there where you might want to monitor an athlete from a seizure standpoint. I can't say I've done that yet myself, but it sounds like a nice new use case that I might bring back to my practice.
And the next questions, it's around the percentage of your patients that you've prescribed REMI versus typical 72-hour wired.
I don't see it really as a dramatic alternative or something that's cutting out kind of our ambulatory wired volume. I see this as an adjuvant. This is what a extended duration cardiac monitor is to an EKG or a telemetry strip, right? So there's patients that need this data, and we didn't have any way of collecting it. And so I've been able to build an entire new volume of patients who benefit from EEGs. And I've followed up ambulatory EEGs with Epitels as well when I've needed later time points. So it's really been more of an adjuvant than an alternative for me in my practice. I think another thing that, we didn't talk a ton about, but it, has some value to highlight too is kind of the idea of this being used as a pediatric device, because it is approved down to the age of 1. There's a lot of stigma for especially pediatric patients going into a school setting or a sports setting, wearing, a big turban and having to have a wired device in a backpack. Also, with complex epilepsy, a lot of these patients have severe neurodevelopmental disabilities, and they pull off anything that's adhered to the skin. So I've had some good use cases where we've been able to put on the device in patients that haven't been able to get an epilepsy monitoring unit stay without anesthesia or a traditional wired EEG in years, and actually capture some ictal events that correlated to behavior and agitation and were just being treated really with like sedatives and traditional antipsychotics instead of titrating their seizure medications more.
There's another question coming in on another channel around the experience patients have with the stickers and taking showers and just the what it's like to wear it for a week or two.
Yeah, so I think if you asked any patient and even patients in the epilepsy monitor unit, wearing wired leads for a week or two is not a fun experience. It's not a positive experience. A lot of them, especially younger patients, suffer scalp breakdown, and older patients too, in like the ICU, critical care setting. I've never had a patient complain about the REMI device causing a ton of irritation, about it interfering with their day-to-day life. I think there are some precautions that you have to have here. If you know a patient is going to take the device on and off, you do want to give them the hotline to be able to call in for assistance and potentially mark the orientation of the leads as well so that they're not flipping them up and down. But in general, patients are smarter than we sometimes let them believe, and they're able to figure out how to put these things on and off. And showering is important for human beings. So they really appreciate being able to do their daily activities and sweat and live real life with something collecting some brain activity.
Another question that came in is, are there any restrictions you think of for wearing the device? The system can't be worn when you go into an MRI room or when you're getting a CT. The nice thing is it's really convenient that you can take it off, get an MRI, and put it right back on in a matter of moments with a new sticker. But it does have metal in it, so we remind people can't go in an MRI room. And then the other thing is that we tell people they shouldn't wear a hard helmet, that would put pressure down on the sensors. But if they're wearing a loose fitting cap or something that is just loosely wrapped around the head, it can actually render the system invisible. And the last question I see coming in here is just, can you describe the REMI 10 channel versus a traditional 1020?
It doesn't have the spatial representation that more leads have, right? And so, when you're having a traditional 1020, you're going to get more central leads. If you have a event that's purely central, which is pretty rare from a seizure standpoint, or something that is more occipital, a traditional wired EEG might do a better job characterizing that. Otherwise, it seems to have very good sensitivity, for other locations, particularly the frontal and the temporal regions. And for a lot of patients, that's really enough to answer kind of the binary yes, no question. But that's why I really see it as an adjuvant instead of a dramatic replacement at this point. I think, like all of epilepsy, we have lots of different tools to build a diagnosis and treat patients. And this is a new, exciting tool that pushes the limit when it comes to time windows. But you're not going to go surgical plan a patient without, like a phase two stereo EEG still, right? So, there's always going to be different levels of spatial data that you need for different levels of decision. Well, it was a pleasure to speak to you all, and I appreciate your attention and excited to have more talks. I'm happy to answer any questions asynchronously through that REMI Institute email if they come through later.